Is there such a thing as an atraumatic extraction? I remember one lecturer in oral surgery, she was up in the podium and she said, this is BS because all extractions should be atraumatic. But in the real world, from my experience, I know that my implant colleagues would do something called an atraumatic extraction, be very proud of it. And from what I understood, it takes a bit more time. Like, you need to be a bit more gentle, you need to preserve that precious bone. But from speaking to our guest Diyari Abdah today, using specialized tools such as the Piezosurgery, like this was all pretty new to me in terms of its applications for atraumatic extractions, but using that, your atraumatic extractions don't have to be very slow. They can actually be very efficient. So that was a real takeaway for me. Hello, Protrusive. I'm Jaz Galati, and welcome back to another episode of your favorite dental podcast. Today, I've got Dr. Diyari Abdah, who's such a fascinating man. Like, to me, he was this educator and implant dentist in Cambridge. From our conversations, I figured out that he's been nominated for an Emmy before. He's got an MBA. He's a best-selling author. He's got books on business, completely not related to dentistry. He's a really smart cookie. And I'm sure you'll find him very fascinating. But in terms of what we're covering today, it's all about atraumatic extractions. What do you need to use? Can you just use luxators and do everything you need to do with that to call it an atraumatic extraction? What is different about an atraumatic extraction compared to a regular extraction? And what are the benefits of doing it in this way? Before we get to that though, the protrusive dental pearl. So today's pearl is philosophical in a way. It's going to give you just generic life advice. And it's something I just came across in a book, and I just want to share with you guys. Never take advice from anyone who you wouldn't aspire to be like. So there might be an amazing dentist, let's call it a male, for example, male dentist, who's really cool, but I wouldn't take advice from this dentist, even if they're an awesome dentist, if they were abusive to their wife and their children hated his guts and he was failing at every other aspect of his life and he wasn't looking after his health, for example. So that's someone who I wouldn't want to switch places with, because for me, I value family very much and I value relationship with children, etc. So just because their dentistry is good, I wouldn't take advice, and especially life advice, from someone who's failing in that regard. And it's because I wouldn't want to switch positions with that person. So I'd only take advice from someone, because advice is quite freely available nowadays. You have to kind of be selective about who we take life and clinical advice from. So always think, as a rule of thumb, never take advice from someone who you wouldn't swap with. If you wouldn't trade places with that person, you're probably not best taking advice from that person. This episode is brought to you by Enlightened Smiles, the premium brand of teeth whitening. If you do their online training, which I've talked about so many times before, the link is in the show notes. It's well worth it, even just for the 1 hour of learning you can do with Payman Nangrudi. Their training is awesome, but I posted a case recently on my Instagram and my Facebook, so it's at Protrusive Dental for Instagram, and the Facebook page, just literally type in Protrusive, a full protocol, so 10 images on Instagram, because that's the cap, it's kind of annoying, and about 25, 26 images on Facebook, how I replaced this lower incisor that was aesthetically failing and a crown on the upper right 4. But also, as part of that case, we did some teeth whitening with Enlightened. We got a great result with that. So you can see the kind of results I'm getting with my whitening, plus the vertical preparation that I did on lower incisor and how I replaced a aesthetically unacceptable lower incisor crown. So that's all available on social media for you to check out the full case. And thanks again to Enlightened for supporting the podcast. Now let's get to the main episode with Dr. Diyari Abdah. Dr. Diyari Abdah, welcome to the Protrusive Dental Podcast. How are you?
I am very well, my friend. Thank you very much for having me. I'm a big fan, by the way, for what you do. And it's just amazing, you know, the way you describe things.
I really appreciate it. And I'm excited to tap into your brain and share the knowledge with everyone. And just so, you know, I always like to give a little bit about how I know someone. So I know you through Dylan, your son, went to dental school together. And when he, you know, he's always spoken very fondly of you over the years. And I actually didn't know how involved you were with education, implants. And I thought, okay, we have to do an episode. So we were kind of brainstorming, okay, what should we talk about? And one thing that's always talked about is atraumatic extractions and peri-implantitis. It's two separate things, but that's the main theme for today. But before we delve into that, Dr. Abdah, just tell us a little bit about yourself. You're obviously very much into personal development, because you're talking about Tony Robbins via WhatsApp the other day or by email. So just tell us a bit about, you know, who you are, where do you work, and where you developed this interest in implants over the years.
Sure. Thank you very much again for having me. I really appreciate it. Yes, I mean, Tony Robbins had a big, major influence in my life many years ago, over 20 years ago. And in fact, Dylan was with me. He went there on his 15th birthday party. You know, fathers probably take their kids to the cinema or somewhere. I took them to Tony Robbins to walk on fire. Thank you. So we have the hat and we have the certificate. So we've done it, been there. So no, it's always good to revisit these things. I mean, one of my mentors, my motivational mentor said, motivation, or it's a bit like it's a bit like taking a shower. You can't be motivated once every 10 years and say that's it. And it's like a shower. You have to take it every day. So there are all these routines you have to get yourself into. Now, saying all that, I mean, that led me to a different path altogether. I was talking to college students in the States, telling about my story, how I all started. And sometimes you need to hear from somebody else, your story. And it was quite a humbling experience because that led to something else led to something else. And doors opened and I met great people, like yourselves. And when you have an open mind, like a parachute, you do land well. So we ended up doing some charity work in Mexico for orphans. And at the time, they invited some filmographers from Hollywood, and they did a documentary. And then one day I get this phone call to my clinic in Cambridge. I'm just this little humble dentist in Cambridge. I get this phone call from the Emmy Award nominee committee, and they said, well, Dr. Abdah, you and your wife are invited to the Emmy Awards because you were one of the producers of this documentary, which has been, anyway, long story short, the documentary got an Emmy Award, so we got an Emmy Award. So I can brag and say I'm an Emmy Award producer, but that was all for humanitarian efforts. And also, I always wanted to develop. I always wanted to go further. So going back to my dental background, I have 2 dental degrees from 2 different countries. Believe me, that's not by choice, my friend, because I studied in Romania for 6 years, and then I could not go back to my country at the time, which was Iraq, and I had to move somewhere else. So I went to Sweden, and at the time, Sweden was very, very welcoming, but also very difficult in the face of foreign certificates. So, the study in Romania was unbelievably helpful in terms of practicality, maybe not so much technological. Now I go to a place where it's all about technology, but the practicality was quite funny. Talking about extraction later, when we had extractions, 3-4 students had to train on the same patient because one will wiggle it and the other one will do something else. And then we all pretend the tooth is out, we put it back in. Only because the oral health in Sweden, apart from the chewing tobacco that they use sometimes, it's actually quite high. You don't see many people with dentures. You don't see many people. And of course, I was at a clinic where Brånemark was only 20 meters away in his office, and some of the biggest names now we hear in the world of perio or implants, they were all either with us or something. So you can imagine being in that environment. And now, I finished Sweden, then moved down here to UK. I did my master's degree in implants, very early stage. But for about 3 years, this is the interesting bit, for about 3-4 years, I was actually I don't mean any disrespect. I think there's greatness about being just a general dentist, just doing your thing. Listen, as long as we all do what we do perfectly, I think that's great. The trouble is trying to be master of everything because you're going to be master of none in the end. So general dentistry, I loved it. But I wanted to move on from there. And this comes from a guy who, and I just say this to your audience because I respect you and I respect them. This is coming from a guy who probably didn't like to hold a scalpel in his hand, for a few years. I thought, nah, I don't want to do it. But then I fell in love with implantology. It was still quite a novel thing to do. I mean, when I finished my master's degree, I think there was only probably in the tune of 20 people in the UK who had master's degrees.
Okay, so Diyari, what I want to just pick on further is, how did you know it was your calling? Because if you hadn't placed an implant before, I imagine, before doing your master's, and you correct me if I'm wrong, and there weren't many people doing implants, how did you know to commit to something that was almost like a novel field? I guess it's a bit like someone nowadays committing to laser dentistry, having limited experience in lasers and committing, into a master's in laser dentistry and whatnot and going all in. How did you get that sort of premonition?
Sure. Well, the thing is, as I said before, we were actually only a few meters away from Professor Brånemark's office. And this is a guy we used to see, around the cafeteria. He used to hang around sometimes, talk to us, always in that bow tie. And so everybody wanted to be him. Everyone wanted to be. I can't imagine anybody in my class who actually didn't want to place implants. I think I haven't followed everybody, but I think most of us actually became implantologists in the end, because there was just such an aura, it was in the air, you know. In Sweden, at our department, they did train everybody on implants. So when we came out, we were actually ready to place implants. We already were certified to place implants.
Wow.
Yes. So as a result, I was already placing implants, and then I thought, well, I want to go a bit deeper in this and do a master's degree. Little did I know that the master's degree was more academic than practical. So I still then had to go and pursue other forms of knowledge. And basically, in anything you do, if you want to do it well, you need to look who's the top guy, and you go for that. So I had my eyes on somebody for years in the States. So I just pursued him, and I went to him and I said, look, I want to learn everything from you. What's there to learn? And then I spent a good time with him.
Who was it? Share the name.
This was Professor Dennis Tarnow. So Professor
Amazing.
Dennis Tarnow, he's very widely referenced everywhere. I mean, you cannot do your master's degree if you don't have gone through 200, studies of him. So anyway,
yeah, I mean, I don't do implants, but I still appreciate Tarnow's lore of 5 millimeters from the crestal bone, the papilla, that kind of stuff. That's all from Tarnow, right? If I'm not mistaken.
And he's just an amazing guy. So and then again, there was a late Carl Misch as well, and I also approached him. So with Professor Tarnow, there were a few courses happening that I attended. It was very, very it was only for like 20 people, and you got to spend a week with him, and that was great. And also with the late Professor Carl Misch, I spent some time with him as well. And these are by far the two biggest names out there. And of course, there are other people whom I respect. So I'm still, despite I've been running courses and lectures and things, but I'm still a student, because the learning never stops.
Absolutely. Well, we're going to extract some more fundamental, basic concepts from you today.
Sure.
To help those protruserati listening in and want to gain some nuggets, maybe on their commute to work or chopping their onions as they usually do. Let's start with atraumatic extractions. Bit of, I once remember this lecturer, this oral surgeon, at the front of the podium, and she said that atraumatic extractions is BS. And she said this because all extractions by nature should be atraumatic. So why do we have this entire separate field called atraumatic? Another thing I want to just mention as a build up to this is I remember being in DF1 and an extraction was, okay, we can do this, but if you wanted an atraumatic extraction, it was going to cost you a little bit more. Can you believe that? So tell us, what do you think about that statement about, there's no such thing because all extractions should be atraumatic? And then also, what actually is an atraumatic extraction?
So so shall we agree on something? Atraumatic extraction, should it cost more? Because, I mean, the question here is this. I was thinking, just seriously, I was thinking the other day when he sent me the question, he said, I want us to talk about atraumatic extraction. I've got a series of lectures that they're called the dreaded extraction, So atraumatic extraction, I thought, this is a very interesting question. Who is this atraumatic to or for? Is it to the patient? Or is it the bone and the surrounding tissue? Or is it to the dentist? Because, nobody wants to do a difficult extraction on a Friday night, and usually they happen Friday. That's why I don't work Fridays. So I don't see any patients for extractions. It's just laws of universe. So I think the definition of atraumatic extraction, we can all agree on, it's probably the best definition, or the most clinically accurate definition would be atraumatic to the surrounding tissue, bone, soft tissue, everything else, and then depends where you want to do with that socket. I saw a video of yours. You were doing some extraction, and I know you're a big fan of separating roots, and I totally agree with you. Sometimes, in the old days, we used to sit down and try it with a root and wrestle with it. And in the end, after half an hour, 40 minutes, people say, oh, let's get the drill out. Well, why didn't you get the drill out after 2 minutes, or from the beginning? Why didn't you
It took me years, Diyari, to actually gain the confidence and the awareness. Actually, why don't I just skip the trauma-inducing part and actually go straight to make my extractions easier, but by sectioning the teeth. So this is I'm a huge fan of that. So atraumatic extraction, as you said, is making it kinder to the bone, to the soft tissues for the patient. And so when we are training at dental school, the way I was taught was we had to only use forceps. We weren't even allowed to use luxators because what if it slipped and the luxator went through the floor of the mouth or something, right? So loads of us were breaking crowns off, and then we were being rescued by the tutor who'd come and then raise a flap, draw some bone, section, etc. So that's our background. Obviously, you learn to use luxators and stuff. So if we want to be atraumatic in our extractions, what are the additional skill set that we need and additional tools that we need to be able to achieve that?
Very good question. Now, atraumatic extraction, my story with atraumatic extraction started with luxators. And you're right. The whole notion of atraumatic extraction is that instead of horizontal wiggle, you try to lift the tooth out vertically. So it's through vertical forces and whatnot. So that then comes the separation of roots. I sometimes in the past had to separate an incisor root, going from distal to mesial, so I can separate, so I've got more control of the buccal. Or sometimes in implantology, lately there was this trend to do this, leave like a flake of the root buccally, so that you don't, that proved to be not such an exceptionally successful thing. And mine has evolved over the years. So I completely agree with what you did on that video. And I think that's amazing, because that was I think it was the upper molar that you were separating the roots, taking them out one by one. And I was looking at where you were keeping your fingers very accurately, especially that buccal wall. Until you take CT scans of the mouth, case after case for implants and things, sometimes you just don't realize, or you forget how thin this buccal bone plate is. It's just paper thin sometimes. So at all times, that finger has to be there, whether you use luxators or anything. But lately, I've gone into piezosurgery, and I like to talk a little bit more about that, because I think that's something which is doable, because you're talking about tools. That's something that's doable. It's actually very cheap to buy a device nowadays. I remember my first device I bought, that was like £15,000. Now, in the old days, most of implantologists and bone pickers, we all bought these big devices. They used to come in a big box and massive device, but they were pretty much useless. And that's why most of us, the device ended up in a drawer somewhere. I was actually thinking, where's mine? I'm sure it's not in eBay, but we don't even know where it is, because they were slow, they were hard. It was actually hard work. So sometimes the extraction took me like 10 minutes. With a piezo, it was taking me 45 minutes. I'm like, what's the point in this? Now they've changed. And I had the fun and the privilege of being part of a study with my good friend, Professor Angelo Trudham from Vienna, who's the president of the International Ultrasonic Surgery Association, or Academy rather. We were doing a research study at the University of Bordeaux a few years ago, just before COVID. And the beauty of that was that we had some human cadaver specimens that we were working with, so it was a real deal. But also, we had every single, I think this was 2019, and we're supposed to be publishing a paper at some point, but that got delayed because of COVID. We had every single piezo machine out there that's available on the market now. We had about 12 of them. By the way, I told you in the beginning of the whole talk tonight, I'm doing something for the first time ever in my life, and that is talking without my slides. So, so we have to describe things now, because there's a photo of me on my lectures. There's a photo of me there with all 12 machines in front of me. So it was a bit like a Top Gear kind of thing. And it was nice. It was me, two other professors. We were having all these toys, and we found out that they were not all the same. No wonder why some people get frustrated. So this is the problem. If we buy the wrong one, we might end up frustrated and losing, our enthusiasm and everything. So I'm not going to say
excuse my ignorance here, but just wanted to bring this in. We're recently doing up the surgery where I work in at the practice, and my nurse said that, oh, Jazz, you won't be having a cavitron anymore. You're going to have a Piezo. I'm like, okay, fine. Can I still do what I want to do with it? She says, yeah, you can do what you want. So, but now, will I be able to use that Piezo unit, which is primarily there for your scale and polish kind of stuff, and to remove calculus? Is that the same Piezo I can use for surgery? Is it different?
No. Excellent question. No, that's not. That's not, because it's all in the frequency. We need to know which frequency are we using. The ones we are using. So basically, at the end of testing all of these, we found out that 3 of them were top, got top mark. And the one I use, without mentioning names, I'm happy to say it if you push me, but
you can mention it. It's fine. It's cool. It's cool. You can mention it.
Yeah, so it's called the Cube. It's from a company called Action. It's a nice little cube. It looks like it was designed by Apple. I mean, if Steve Jobs designed piezotomes, he would design this. It's all little, and I call it the Jackie Chan because it's very cute but very powerful. So that that works with a frequency of between 24-36 kilohertz. And what it does, so what they do, the one you mentioned about, you might get away with certain things, but definitely not bone cutting and all that, and I hope not. So the way these work, they work in two ways. They work through ultrasonic vibrations. Okay, so they've got ceramics inside that vibrate through a transducer, and then that translates into the vibrations and the ultrasound or ultrasonic into the tip, and that's how you cut. But then there's water coming out, as they do, and the water creates this cavitation effect. And the cavitation effect is like micro explosions. When water, it's almost like micro boiling phenomenon happening in the liquid that's hitting the hard surface. I call it micro explosion, basically. So what it does, it gives you better visibility, it gives you hemostasis, and also it has an antibacterial property. Why? Because it can break down bacterial cells walls that are in that vicinity, which is amazing. You get 3-4 things, which means it will decrease morbidity and increase predictability. Now, what are you going to do with that socket? That's your business. Okay, are you leaving it? Hope not. Are you putting some collagen plugs in there? I hope so. Are you putting graft material in there just to keep that bone architecture? Wonderful. Or are you placing an implant? And of course, I developed this technique called the 360 technique, which has been trademarked and all that. And that is exactly to show how you go about, because it's not just kind of sticking this tip into the periodontal ligament space and hoping that things will break down, because after all, it's designed to cause like micro shattering of the mineralized tissue. And the mineralized tissue definitely is not the periodontal ligaments. So why are we breaking here? So we are actually breaking the bond between the periodontal ligaments and the roots and the cementum. And that's where these if you can imagine, a Saturn V rocket in the days of Apollos, how this whole scaffold will come off before it takes off. So that's where we are trying to break down all these ligaments. So then the tooth, I had teeth, an upper left 2, I think it was, if I remember. It was beautiful. After we finished all this, it actually popped out. I didn't even need to lift it, because the water got underneath it, just like the pressure made the tooth come out, and that was beautiful. Now then, after that, obviously, you have the thickness of the bone that you have to then preserve, because depending what you do with it. So going back to atraumatic extraction, to simplify everything, it's any extraction that allows you to keep the surrounding structure intact to quite an extent. So then you could do what you are planning to do with it. Now, you do that through separation, wonderful, and luxators. I've done hundreds of those, and they're amazing. Whether you do that through the...
And that's about my limit. That's about my limit, Diyari. Like, I don't know what... I couldn't tell you what a periotome looks like. I've heard great things about them. Maybe you can tell us about it. But my limit at the moment, my knowledge base is luxators and sectioning. And those are my skill sets that I use to make my extractions atraumatic, but also just for me to make my extractions predictable more than anything. Atraumatic is actually a secondary outcome for me, and being preserving of the soft tissues and the hard tissues. So I don't know much about periotomes. I don't know if you're going to go in that direction. Are they useful?
Periotomes are just like the nicer cousins of luxators. They are just kind of a bit more. They're a bit more finer. They go in that ligament space easier, better maybe than narrower, and they have different shapes, so you can use it for various corners and things like that. It's a bit finicky and a bit more fiddly, but does the job. But
do you use them much, or do you just use your bog standard luxators?
I used to use them. I tell you exactly what I do. I use for every extraction, and now Dylan, my son, he also uses the piezo for every extraction, every single extraction. So we are fighting over it. We have to buy a new one now. And so no extraction.
Let me just make this really tangible. Sorry, Diyari, I just want to make it really tangible, right? So the patient's numb. Let's say we're taking out a lower molar, lower first molar. Patient's numb. You're going to take your Piezon. It's probably a specialized tip of some sort, and you're going to use it, I guess, in the PDL space all the way around. And just to describe it, because again, I've never seen this before. It's something new to me. So you have to
absolutely
explain.
Fine. One piece of advice is if somebody gets excited and they say, "Let's get one," the trick is not to. You don't have a scalpel. So the idea is, even if the tip looks very aggressive and pointy, the idea is when you go into that PDL space, you don't go back and forth. You actually go in a pumping direction. So basically, continuously you're going up and down into that space. Why? You want to allow the water, the spray to go in. That's where the cavitation happens. And also, the idea is you don't want to cut these, because if you want to cut them, well, you might as well grab a luxator, you grab something else, So you go around them. And then you notice how all of a sudden the tooth becomes slightly looser. Then you go back to your luxators. That's absolutely fine. And you do that. Or even sometimes I use the piezo. I go with my luxator. I go with a separation. And then I go back to my piezo a little bit. And this whole dance could take no more than 7 minutes, but it just happens quickly. Everything happens predictably. That you said the word predictable before. That's the name of the game, my friend. Whatever we do, whether it's a simple, humble buccal filling to I don't know what, is predictability. And so that's what you do. You got the machine, patient is numb. It's a lower right, let's say 6. And it's amazing if you break a root. So remember if we broke a root, automatically the bone drill comes out and the whole thing, and this entire army of tools will come out. Well, no more. I mean, sometimes Dylan shows me where a tooth came out, but the tip was a little bit curved or something, and he just grabs the piezo. And because of that cavitation, there's so much water going in. Sometimes the water actually just lifts that root, as long as you create that space around it. And when you look down, I'm sure it cuts a little bit of the bone, but nothing that the normal human eye can see. But that's enough for the tooth to be loose and come out. Yeah. So gone the days when I used to lose. If I didn't do many 360 socket preservations, I wouldn't actually go and trademark the name. 360 socket preservation protocol, because you can't be trading a name or trademark a name where it only happens 50% of the time, and the other 50% it doesn't happen. It's a bit like Apple saying, well, we are Apple, but sometimes we are oranges as well. It doesn't happen. You have to be consistent. So in that case,
are there any studies to show how much difference it actually makes? Like, studies of teeth that were extracted without, using techniques that didn't involve the Piezon versus techniques that did involve the Piezon, how much more bone you preserved?
Absolutely. I mean, there's so much study out there. There are actually so many books nowadays on the topic. And if at some point your audience would love to see a list of things, I'm happy to provide you, and then you can put it on the Telegram or on the chat or somewhere that they can see. Sure. Because it's great, because there's so many we can't even talk about them now. But one thing, let me just tell you a funny story, is all these things are wonderful. We are all clinicians at heart, but it's also a practice builder. And I tell you why. One day I see this patient coming, lovely gentleman, and he is sitting in the chair. I look, he got an upper right canine broken completely, so just a root there, but it's a bit of that nasty diagonal fracture. So I look there and I say, yeah, so what can I do for you? He said, well, I would like to take this tooth out, but I want to preserve the socket. Now, all of a sudden, the alarm bells start to ring. Preserve the socket. Is he a dentist? What's he going on? How does he know about the socket? Did he have a bad experience before? Anyway, long story short, he told me, I'm in Cambridge, as you probably know. This guy came from Northumberland. Now, I think that was a good 7-hour drive. And I said, why here? He said, oh, my general dentist said that he was at one of the dental shows and he heard this guy lecturing about piezo, and he showed case after case and slide after slide how he managed to scoop out these roots out of these most difficult areas, and he preserved the bone for later on to use it with an implant. And he said, because we need to place an implant and he doesn't do it. He said, so he said to me, you should go to see that guy. I said, well, that's wonderful, but how do you find me? how did you find me? He said, well, I had to ask him. He had to look up, to see who lectured on that day, what happened. And then he sent other people. And then people send people because they say, oh, it's so easy. I didn't feel a thing. And Dylan has a little trick. I like it. He takes the tooth out. He finishes everything. And then he will say, so now you might feel a little bit of pressure as we do this. And the patient says, okay. And he says, no, I'm joking with you. The tooth is out. I love that line because it just puts people at
That's
ease.
such a Dylan trick. I know Dylan, and that's such a Dylan thing to do, and I love it.
And to me, that's like handing a referral card to somebody and say, could you refer other people to me? It's amazing. Seriously, it's a practice builder. And you were talking about your level of expertise in the separation. I would love to invite you one day to my clinic and just show you a few cases, and we can get some models. You have a go at it, and you just find that it's so much easier than doing other things. Now, I did this test, which I shouldn't have done. I know probably this is going to be on the internet, as they say, all the wwws. But we were doing this clearance down here, so it didn't really matter that much. Implants were already. We had 2 kilos of graft material there already. So, and I told the patient, I said, I will do 2 things here: one side of the mouth with this, one side with that. And he said, okay, that's fine. So signed it all. That was all cool. So I did one side with a piezo. This is just my own clinical thing. One side with a piezo, and I did the other side just with luxators. And this is, by the way, is not a secret. It's all of our lectures. And on the other side, I broke the buccal bone on one of them, and on this side I didn't. Now, whether because I'm now used to the piezo and I use it before the luxators, because like I said, my luxators are complementing my piezo, that's a different story. But just pure luxator, and that bone was so thin, it broke. So of course that was the area that we had to grow most bone, and the case was successful later, and we placed the 8 implants for him, and he's happy. But what I'm saying is that whatever works in your hands.
That was a good opportunity for a split mouth study, and I'm glad you did it.
Exactly, with the patient's permission, and I knew that we are not risking anything, so the effect will be good anyway. So the idea is, once you do this 360 socket preservation, and let's say that you are an implantologist. If you are not an implantologist and you are just doing it, patient broke teeth, general practitioner doesn't do implants, they have to do the extraction. Well, instead of sending a mess later on to the implantologist, they will love you if you send them a nice healed socket, beautiful width, beautiful height, everything. And if you've done some nice cleaning and decontamination of the socket, then even better. So I think we ought to do it. We have to do something with any socket that we take a tooth out. So, and we have different levels of grafting. We say, look, even if you don't want to do anything, because some people don't want to do anything, we say, look, why don't we just place some collagen plugs for you? At least it will act like a kind of mini scaffold. It's good for a while until you figure out what's what. Okay, so
I'm glad you said that, because my next question was going to be, most dentists listening to this won't have a Piezo on, but they're now going to, their interest will be piqued, and they'll be like, whoa, okay, this is something new for me, and they're going to look into it. And any papers you send, I'm happy to link to them. So that's really good. But then I was going to ask you for a tip or some advice that you can give for the everyday dentist, young dentist who wants to be atraumatic, and you've just given it there. So to use a collagen plug, just tell us a little bit about that. Does it matter which brand it is? How does it actually work?
Okay, so the brand, I would say, to an extent, stick to a well-known brand. You got things like Bios, like Geislich company. You got Biohorizon. They do the BioPlug, which we are a big fan of it. I use it a lot. Dylan uses it all the time. And they look like root shape. They look like a bullet. So all you need is just to form it ever so slightly, and it just goes down there, and it keeps that shape. So basically, what happens? It will integrate with the coagulation, and becomes an extra scaffold. Obviously, is not bone grafting per se, but still it will buy you time, and it doesn't allow the crystal margins to collapse on themselves, because as we all know, when you leave a socket to heal, as it's trying to heal over time, we lose the margins because they come down as part of that healing. And before you know, we lost 3, 4, 5 millimeters. And then patient might knock your door again, Mr. General Practitioner, I love you, but I now like to have an implant. What can we do? and you send, and I had that. That's what I'm saying. I had people being referred to me, and when I look at the bone, obviously you have to be careful what you say, but I'm like, I just wish that you place something here, just a scaffold, and they are cheap. I mean, those collagen plugs, I think you're looking at probably 10, 15 pounds a plug or 20 pounds a plug. So they're not that expensive.
Is this different to the one that I have in my clinic, whereby it's a cube, and then we sometimes cut it into two and put it into like the mesial root and the distal root? I don't think these ones are that expensive. I mean, not that that's expensive raw, but it's much cheaper than the 20 pounds. So are they a different brand, a cheaper brand, do you think?
I think the cubes are made in such a way they're very spongious, whereas if you have the two of them and you play with them, you notice with the cube you can actually, if you squeeze it, it becomes almost like paper. You can squeeze it all the way.
Yes,
this one
it becomes
has
flattened. It's like
flattening
flattening a cardboard box. Yeah.
This one is woven in a different way, so it has a bit of a resistance. I mean, some of them go as far as they're woven in such a way that even if you press it, it's almost like it bounces back a little bit to its shape. And that's something you need compared to those. Listen, at the end of the day, something is better than nothing. And even the cubes, probably half of my career, I used to place those cubes, and they were fine. But just leaving a socket. But one thing is very, very important. We've done the extraction, we've done everything. And I hope, sincerely, I hope that everybody grabs that curator or something and just clean the heck out of that socket. That's the problem. Sometimes we take the tooth out. It took us half an hour. We are shattered. We just want to send the patient home. No, clean it. And nowadays we have these saline in a little kind of injectable tube kind of thing. I don't know, it costs probably pennies. Just kind of wash it, rinse it a few times, and then put this thing, maybe a couple of stitches, maybe not. And then you send the patient home, everybody happy, and they thank you later. And the implantologist will thank you. And going back to our
Diyari, at the moment I use something basic, the spoon end of a Mitchell's trimmer, something as basic as that, and I really spend my time to clean it. And I feel as though over the years I've got less dry sockets since I started to clean the socket. And this is something that I didn't always know. It took me 5 years. I've done school, an oral surgeon I met who helped me, taught me to do this. And then because it was over the shoulder teaching, I then inherited it, and now I pass it on to the other dentist when I went by the chair side. I said, no, we're not done yet. Pick up the Mitchell's trimmer, get the spoon end, clean it. Do I need anything more fancy than that, or is that okay?
That's perfectly all right. And I think you're doing a great job there. You just mentioned a word that I forgot. Since I use the newer piezos, which is about 7 years now or 8 years for every extraction, I haven't had one dry socket. None, zero. Because
before I would never have believed that, but now that I've had such a decrease in myself, I totally believe you.
The thing is, it's not me. It's a technique. It's a device. Because what happens? Because it has this antimicrobial property, whereby the microorganisms' cell walls break down. Remember, through that cavitation, through that microboiling. So your chance of success is much better, much higher. Now, I must admit that maybe another reason I don't see many dry sockets is because probably 8 or 9 out of my extractions end up with an implant, because that's what I do most. And therefore, by the time they are referred to me or they're in my chair, but you ask Dylan the same thing and he will tell you the same thing. I don't think I've ever heard him say about dry socket at all. So yeah, these are the things. If anybody is using just forceps, that's a big no-no. So the takeaway from here is that either follow your technique, which is amazing, the separation, I still do it today, or you can add another tool. And hey, we are dentists, we love tools, we love gadgets. Anything that you could plug in a wall and use it, I'm all for it. So try to get to any company really, but one of the good ones is, like I said, is the cube from Action. There's
I've heard
NSK.
Great things about Action. I mean, if I've always considered actually before when I was doing a more root canals, they had these really cool instruments for tips for root canals and stuff. So if I buy a unit, for example, if I was to get a Piezon unit, for example, from Action, is there a such thing as you use it for the surgery, but also you have restorative uses as well? Or is it exclusively for surgery?
There are so many tips that you probably fall in love with all of them. I mean, you've got prep smoothing tips. You got this tip. You got, obviously, I use it a lot for bone cutting.
Now we're talking. Now we're talking.
So for prep smoothing, for perio, you know, for root planing, for all kind of stuff. Every time they come up with a new package of these tips, I'm like, oh my God, here we go again. So now we have to get more tips. So, but it's seriously, it's unbelievable. It's unbelievable. My sinus lifts, all of them are done with a cube. So that's why I call it the Jackie Chan. You know, it does it with a smile, but it's very powerful. It does everything from the small thing to the big thing. So it can kick one person, it can kick a whole gang. So that's on atraumatic surgery. So I hope, and because of that, obviously, it will be atraumatic for the dentist, hopefully, you know. That's what we said.
Yes, and more predictable and less failures and less dry sockets, as you said, and that's good.
So next thing, I think if somebody finds in a dental show anywhere, go speak to them, talk to them, see what they have, what they show you, and then maybe they run courses. There are courses all over the place for these kind of things. We run it as well. So go and get that technology. It's not expensive. It's just a bit more expensive than a top-end descaler, really, nowadays. Yeah.
No, I mean, it's great. I mean, I knew there were uses for endodontics and preps and stuff, but then the way you describe this is all new information in terms of the 360 technique and how much of a difference it can make. So I'm sure lots of dentists listening have gained from that. You mentioned your courses and stuff. So Diyari, tell us about the implant teaching that you do, whereabouts you do that, how is it run? There's lots of courses out there, but what is special about yours?
Sure. No, thank you for that. So I've been teaching and lecturing all over, and for the last probably 10, 15 years, I think, but I've been talking over 250, 300 times in different places, both in the States here and all over Europe. And mainly it was about techniques, you know, certain techniques I teach or certain things. And I always had this idea of this academy at the back of my head. So my academy has been in the making for 10 years now. And I thought, if you do something which is part of your legacy, I better do it perfectly and not just half-heartedly. So it's been 10 years in the making. And finally, before COVID, I started the academy, but then COVID happened. And then because most of the things I teach, they are all hands-on. So I found it very, very difficult, or challenging rather, to do it online. And I thought, I just wait. I know this will pass. So to kill time, I wrote a book that became a bestseller. It's called Business Not As Usual. During COVID, and that went on Amazon.
Wow, I didn't know this. I had no idea.
Yes.
Wow.
Business
is it specific to the dental niche?
No, this is for small business owners, you know, what to do in times of down economics and stuff like that. Because a few years before that, I did an MBA, and right now I'm halfway through my PhD on the back of that. So I thought, you know...
Like you said, the learning never stops. You are a perpetual student.
It never stopped, no. So basically, So then I spoke to a few friends and I said, listen, I need to do something that I always find in courses. I mean, there are many courses out there, like you said, and there are some amazing courses. But what I found that a lot of time there was this information fire hose, and then you go back and there's like, okay, now where do we start? What do we do? So I thought first and foremost, I'm going to give each one a roadmap. What is expected to do till next session so that they start doing it? Number one. Number two, the other problem with some courses, they last 6 months or 7 months or 8 months. Now, I mean, God knows, I've been in courses that lasted a year. I thought I need something that it gives enough breaks to people, but before they forget the knowledge before, we need to get cracking again. So my course is done within 5 weeks. So like 3 weekends, Fridays and Saturdays, and then 2 weekends, there's a break, and then Friday, but there's some work to do in between. And that way the information stays fresh. So that was my next thing. So I had to look a lot into teaching, because I used to teach at, currently I'm a faculty, I'm an adjunct faculty at the University of Illinois at Chicago, at the periodontology department. And also I did some stuff with Warwick as well after, on the master course. So I had this ability to teach and make big things smaller pieces. But then I thought, how do we do this in an accelerated format? So I've kind of created this method where, I just give you enough information that is super, super, super important that you use, rather than just kind of painting this entire picture for you, because people can get that information. They want to know, what can I do in the safest possible way? And again, I'm an expert witness for implantology as well in course of England and Wales. I did a law certificate a few years ago. So I thought, okay, and what is it that keeps them out of trouble? let's do this. So combining all this knowledge, basically it's an accelerated learning format for the busy dentist. As long as they dedicate 6 weekends over the span of 5 weeks, that's what the course is about. So at the moment, it has many courses in there on the DA Academy website. And that's just daacademy.co.uk.
I'll be sure I'll be sure to share that in the comments below and on the show notes.
Thank you.
That
Appreciate
those who want to check it
But
out can check it out. Did you get to place any implants?
Well, at the moment, I was about to say that now at the moment, the pinnacle of the whole thing is this accelerated dental implant course that we are doing. And the way it works, that I will distill every knowledge that's out there to be given in practical terms. So we are ready to place implants. Now, in this country, what we do, we place implants on real models. So these are not human beings, but these models are so real that you have soft tissue, you have to cut it, you have to do all these things, you have to suture it. They're amazing models, very, 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 very super expensive ones. And then from there, the idea is when people want, each candidate is actually invited to be with me for a full day looking over my shoulder. And they can ask as many questions as they want. We have cameras, we have screens. They will be right above my shoulder. They can assist me if they want to. And that's one of the best learning,
I 100% agree. That is the most powerful learning I've ever had. It's always been over the shoulder.
And they're not stressed. They're not stressed. Them doing it while not doing, and you have to have all these codes between each other, go left, go right, do this, do that. They watch me do it. They learn everything in 5 weeks. Then they come and watch me do it. And I try not to put two people together. Every dentist has the right to come for a full day by himself or herself. So they get full benefit of this. I mean, that is priceless. And then, because sometimes people put 2, 3 people together. Now, on top of that, then if they want to place implants, I encourage them either if they are close, they can bring their own patients to us, and then they can place the implants while under my supervision, which I think is brilliant because we have all the tools and everything around us. Or we can arrange to go to their practice for the first few implants. Obviously, there's some that's outside the course parameters, but I encourage anybody who wants to place implants the safest possible way and predictable way to go and visit this, the accelerated dental implant course. And, Jazz, I've always heard great things from Dylan about you, seriously. And when I met you, my respect just grew. And I know this community is very, 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 very close to your heart. I know that. And now they're my community.
The Protrusive.
They're close to my heart,
you're very welcome.
I would love to extend, obviously we have the super early birds, normal pricing, whatever the price is. I would like to extend 10% discount at any stage they want to join to them, as long as they mention your name. That's my gift to all of them, and I hope they take on.
Amazing. I really appreciate that. It's funny, actually, my buddy Clifton, I went to see him in Brighton, and he said to me, Jazz, do you get a lot of course organizers and dentists who teach? Do you get a lot of stick from them? Do you get any hate from them? Because the things that you gave away on the podcast, I paid so much money to get that information and you're giving it away for free, he said. I said, listen, if anything, I think the podcast serves to help identify people who realize, I'm inspired and I want to learn more. So I actually think course organizers have benefited from the podcast because it's inspired people who've identified, I want to do better. I want to do different. I've now decided that I want to niche in this respect. So, and if anyone's looking into the implant world, then I'm sure you've learned a lot from Dr. Diyari today in terms of what is possible in an accelerated program, and from his wealth of experience. And you're very interesting, Diyari, I have to say, with the MBA and this Emmy Producer Award and authorship. You're a very fascinating man. So that's pretty cool. So just tell us the website again. I'll put it in the show notes.
So the website is Accelerated Dental Implant Course. That's the main course at the moment we are running. You can also go to daacademy.co.uk. That has different courses, and we're working on the dates, but the main one is Accelerated Dental Implant Course. And by the way, you can also give them my email. I'm more than happy to answer questions. And the other thing we do after the course, for an entire year, we run this diagnostic and treatment planning WhatsApp kind of connection, so that if somebody's stuck on something, they can always ask me anytime, and I'll be more than happy to plan the case with them. So my main thing is I want, the way I was taught by some people, and they made a big influence and impact my life, I want to impact lives of my dental colleagues.
And that's very clear.
That's the thing. Yeah.
That's very clear. Well, thank you so much for sharing all that. We ran out of time for periodontitis, but we can definitely do a part 2 in some months. But absolutely. But atraumatic extractions, that was really fun. I learned a lot. I'm going to be looking at the Jackie Chan of the Piezo world. I'll be finding the cube and having a look. Actually, you've definitely piqued my interest there. More for the, yes, the surgery sounds amazing, but as a restorative geek, I'm remembering all the tips, the preps tips that I saw to take my preps to the next level. So that's got me very excited, actually. Is this one more thing I can now justify to my wife? Anyway, thank you so much, Diyari. I really appreciate you coming on. Thanks for your time.
My pleasure. Thank you very much. Thanks for having me here. It's been a pleasure and a privilege.
Thank you. Well, there we have it, guys. Thank you so much for being a true Protrusive and making it all the way to the end. I always really appreciate you. If you resonated with what Dr. Diyari Abdah had to say, and you have the appetite to learn more from someone who's so experienced and fascinating as Dr. Diyari Abdah is, then check out his academy, daacademy.co.uk. Again, I'll put all the notes in the show notes so you can check out his complete range of courses. Also, the case that I shared with you on Instagram and Facebook, where I showed about the whitening case with enlightened smiles, that case I actually also did a canine riser. So I've got a full video showing exactly how I did step by step that canine riser. I don't know if you remember, but I've got an occlusal series. Every month I'll send you one occlusal tip. Over 400 of you join my email list for that. It's completely free. And the way you join that is occlusion.wtf. The website is actually occlusion.wtf. You just type in your email address and I'll email you the tip. So when you get the email for the canine riser, I'll also include the video that you might have missed, the very first occlusal tip, which was how to adjust a resin bonded bridge after you recement it for the correct occlusion. So RBB recementation and occlusion, and then the next one coming is canine riser, full-blown technique. I've checked out the whole of YouTube. There's nothing this clear and this good on canine risers out there. This is going to be quite comprehensive and I hope you enjoy it. So do check out occlusion.wtf to sign up for that. And be sure to share this with a friend if you found it interesting. Thank you so much.